this is really going to be about what's in the record and how to get the right stuff in the record. And then coders, we want to be able to recognize it when they say it the way they want to say it. We want to recognize it and report it accurately, and that's our job, is to communicate, what they're writing clinically. They need to say the right things about what they've done for the patient. We'll turn that into the language that the insurance companies understand. That's the coder's kind of responsibility, and that's really what this time today is about. The whole coding and documentation business for reimbursements, the process of communicating the value of emergency care. That's the way I see it. It's about communication. Yeah, this is a business, so we're talking about money matters today. But it starts with the patient, and it will always principally be about the patient. And if anything you hear today, or anything the coding team ever tells you that sounds like you're supposed to do something different for the patient, or say it in a way that isn't clinically accurate, or say that you did stuff that you didn't do, that's off limits. That's not appropriate. That's not what we're trying to do. We're trying to get you to do the right thing for the patient first and foremost, and that's why I say it. You never compromise the trust inherent in the physician-patient relationship. That's what drives everything. And even when it comes down to auditing, when payers come in and audit your charts and they want to take money back, our best defense is, first, we did the right thing for the patient. Insurance company, your beneficiary, we did the right thing for them. Okay, now, insurance company, let me explain all the things we did and why we did what we did. And that's how we're going to use your documentation. But it's always going to be, now you need to pay us, because first and foremost, we did the right thing here. So it is going to be about what did we actually do in the patient encounter, and how do we get that reflected in the work, in the record. So knowing how to communicate the value of your care sets you apart. In an independent practice relationship, I don't know how your compensation relationship works, physicians, whether you're paid on an RVU basis or paid on fee-for-service or just paid hourly. Is it just hourly? Okay. All right. But knowing how to communicate the value of your care increases your value to your employer, be it here or anywhere that you go. Know how to communicate the value of care. Now, that means know a little bit about the CPT system. That's the terminology that the payers recognize to translate your clinical into their reimbursement language, CPT. CPT codes, common procedural terminology codes, they build the content requirements, we follow them, and that's how we end up generating the revenue. So there's economic empowerment to there's an economic component to physician empowerment, and we've talked about emergency. I have often talked about emergency medicine as sort of the, often in the healthcare system we've been looked at as kind of the low man on the totem pole. Everybody gets to look in and see what you've done. You practice in a fishbowl, right? Everybody gets to second guess how you came to your conclusion. Well, after 12 days of admission, we realized the patient really didn't have this. You thought they did. But now we know that they really had that. Well, it doesn't mean that we didn't do the right thing at the right time with the patient with all the information we had at the time. But we tend to get second-guessed a lot. And we tend often to be marginalized to some extent in the healthcare community because you're only the ER docs. Whole separate lecture, but yeah, you also leverage 35 to 50% of all the healthcare dollars spent in the healthcare system in how you determine the patient gets to be managed, but that's a separate conversation. Fact is, when you're generating appropriate revenue, you are leveraging your economic component in the healthcare system. And as we go forward, this whole day is about fee-for-service medicine. It's about line items, right? It's like about how many different things can we charge for. Okay, that's the reimbursement reality today. But if healthcare reform continues in the direction that it's going now, years from now, we're not going to be paid for cranking transactions of CPT codes. If the healthcare reform system works sensibly, what we're going to get paid for is measuring quality. So, how we write our records today to report quality is to some extent learning how to, in the future, write our records to prove that, yes, we did give the right antibiotics at the right time, that shaved 3 days off admission because we got the patient, managed properly up front, or that we chose not to do that CT on that patient. Everybody else would have done one, but we chose not to. We got to find a way to communicate that stuff further down the road in the healthcare system when now payment isn't for how many CTs did you do, but it's for how smart are you to know that you didn't need one. Okay, so understanding how the payment system works really is about physician empowerment. Just a little basic, employers pay insurers, okay? So the dollars in the U.S. healthcare system start with the employer. The employer puts the money into the healthcare system, paying insurers to cover their patients. The whole history of why that is here, different than elsewhere in the world, but the dollars start with the employers. They pay the insurers, who then pay the providers based on some relative value of your work, right? Some things are more complex or less complex. So that's what the RVU system was intended to measure. You got a baseline of say 1.0, and then something that's a value of 2.0 is twice as complex or twice as valuable or twice as much work as something with a 1.0. So that's the concept of the RVU. That's how the payers, for the large part, are determining how they reimburse for you right now. It's based on RVUs. So sets a baseline, and then you get paid above or below based on how the payment system has valued the work. Now, a couple of quick rules, and we'll come back to these. This will permeate our discussion about fee-for-service medicine. But the first rule is no one pays you what you're worth. They pay you what you negotiate. That's a rule of life. We all have inestimable value, but no one pays us that way. They pay us what we negotiate. Now, when we're talking to the insurance companies, yes, the hospital contracts with insurance companies and negotiates a dollar item for everything you do. But the first contract strategy is what we write in the chart. The chart is our first negotiation. That febrile kid who ended up with a final diagnosis of otitis media, I did have to think about some other stuff here. Okay, the kid didn't come in saying, "Oh, and by the way, I'm only here because I have otitis media." It just hurts right there. That's not how the child presented. You had to rule out some other potentially concerning disease processes to get there. Okay, there's value in that ability to do that. So I want the chart to reflect that. I want to negotiate with the insurance company and let them know, yeah, we didn't get fever documented here because mom gave him Tylenol at home. Okay, so yeah, it's 98.6 here, but hey, after 4 courses of Tylenol, and every time, Tylenol, the fever would go back up, mom gave him a little more Tylenol, 2 days of this, and now the child comes in. Right? We want that in the record. We don't just want the final diagnosis. Okay, kid has, ear pain, final diagnosis, otitis media. That doesn't tell the story. We need to tell the true story. In this way, I'm saying we're negotiating with the insurer. That is, we're telling the full story because we want to get reimbursed the appropriate amount. Okay? So you'll hear me later talk about this as a level 4 kind of patient. Now, routinely in a lot of places, it's coded as a level 3. Otitis media is a level 3. Give the kid a script and get him out the door. That's a level 3. But if pneumonia is a differential that you're working with, you're considering, moves the risk from a 3 to a 4. We'll talk more about that. So how we document it is going to be important. Second rule, you don't get paid for what you do, you get paid for what you document, right? And I like Dan Sullivan's rule here. He's a risk management consultant, a sharp guy. I have a lot of respect for. I don't agree with everything he says, but he's a very, very smart man. MD JD. And one of the things he says is, it's not true that if you didn't document it, it didn't happen. That's not true. There's plenty that happened that you didn't document. We can't take time to write down everything. You shouldn't. physicians who are court reporters, and then she said, and then she said, and then he, and then, that's a waste of everybody's time. So we write down the things that are relevant to abstract and make concise the important things. That's what a really good, what a good transcription does, is that it distills all the content, the important stuff, right? So we want you to document. You don't get paid for what you do, you get paid for what you document, because we're going to tell the true story. But what I want you to understand is that what the payment system values now, and will even more in the future, is not just your decisions, but how you got there. It's like, show me the math, show me your calculations, all right? Yeah, it was otitis media, but how'd you get there? Well, the kid didn't look real great coming through the door, so I had to consider, and we did a little lab work. I did a chest x-ray there. Oh, by the way, I'm going to tell you why I did the chest x-ray, okay? And I'm going to say that I think the labs, they're not equivocal. They look like the child's fine, non-toxic. Meningitis might have been in play with this kid because he didn't look good coming through the door, but I can rule it out. I'm sure it's not meningitis, and I'm pretty sure there's no pneumonia here. That kind of conversation is, it's the way your mind works anyway. So we're going to get a little bit of that into the record, okay? Because what you're going to be paid for is your thought process. That's what we're going to say, think in ink. It's about our thought process. How did we decide what we decide? How did we get there? Okay? And then, how valuable is it if the record does not make sense? Now, you all have just gone to Epic. How's that going for you?
Very well.
Good.
So when we go down from Epic and have to go back to paper, it's painful.
Yeah, well, okay, good. Do the records all make sense?
No.
Okay. I understand. That is a, okay, so that's an ongoing. Everybody see or hear about the New York Times article this weekend. Okay. Well, it was on Sunday or Monday, Saturday or Sunday paper. Bob Burley, a gentleman whom I know very well, is featured on the, it was on the front page of my iPad, New York Times. He's a healthcare consultant. Complaining about cloning of electronic records. Now, as a result of that article, Attorney General Holder had to publish something on Monday saying we are very concerned about potential fraud as a result of electronic cloning of records, and we will be investigating upcoding as a result of electronic record, so forth. So this, not really new. We'll touch on this, but it's an issue that the record has to make sense. It has to be true for that particular patient. So records that don't make sense, coders, we're going to need, when we find those, do we get them back to the physicians to let them know to fix that stuff? Yeah, because the system is what it is. Okay, it does some things really, really well, but it also provides ways to make mistakes, and we got to make sure that the record makes sense. Just going to do some quick look back on statistical stuff, just to kind of give you a little benchmarking. 52% in 2010 Medicare patients on average were billed level 5 52% of the time. Does that seem high to you? Doesn't to me. You know what the admit rate on Medicare patients was over the last 3 or 4 years? About 50%. That number is actually low. Okay, that probably should be 70%. 70% of Medicare patients coming through the door are getting level 5 service. They're only getting reported nationwide about 52% of the time. Okay, it's an issue. Medicare patients are sick. They're sicker than the average population. They will get the higher levels. You know, the weak and disease, the nursing home dumps, those are your most complex patients. They will get the level 5s, and the work is being done there. But the reporting system is increasingly recognizing it, and that's caused Medicare to question, are emergency physicians billing too many level 5s? My opinion is no, we're not billing appropriately. We're not billing as many as we're actually doing. But the healthcare system is looking at it saying, here's the deal. In Medicare dollars, just in Medicare payment dollars, the visit volume from 2004, so in 6 years, the visit volume for emergency physician Medicare patients billed by emergency physicians went up 14.6%. It's just 6 years. That's like what, 2% a year. That's not much growth. And when you think about the growth of the Medicare population in total, it's going up faster than that. So we're actually seeing more patients coming into the Medicare system at a rate. They're not coming into the ER at the same rate they're coming into the system. How's that working? Primary care, I don't know. In the past, that wasn't true. But in the last 6 years, there's the volume. However, payments by Medicare to emergency medicine have gone up 45%. Now, why is that? We're billing more higher level services. Okay, we are. We're getting smarter. We're figuring the system out. Hence the New York Times article, frankly. Part of that was about you're billing lots of 5s now, and Medicare's looking at it saying, is it because electronic records are cloning stuff? I don't think that's true. In fact, I'm pretty sure it's not. I look at my own population. We have about 2.2 million patients that we bill for out of our Southern California office. Most of my clients have been with me for a long time. I can look at their admit rates, and I can look at their level 5 rates. They've been doing the same documentation. I've got the same coding policies I've had over the last 6 years, and the acuity's still going like that. My patients, that is patients we see in our billing operation, are sicker today than they were 5 years ago. Okay? They are. I don't know about your population, but that's been my experience. So I think that's happening, as well as we're getting smarter about the coding system. Now, that's all to say. So here's the same sort of thing. These are our level 5s over the last 6 years, nationwide Medicare data. So you can see that's going up. The green line is critical care. That's gone up, right? So Medicare's looking at it saying, the 7th most expensive line item in the entire Part B Medicare budget, that's for all physician services, the 7th most expensive line item is $99285. Our level 5 ER visit. Okay? Medicare paid about $1.6 billion in 2010 for level 5s. So they're looking at it saying, whoa, a lot of money, a big expense. Maybe we need to start auditing this stuff. Okay? And that is happening all around the country. Have you all gotten United Healthcare audits here? You have? Yeah, okay. Are you fighting them?
Oh, yeah.
Please do. Please do not let them get away with what they're trying to foist. This is the largest healthcare payer in the world, largest commercial healthcare insurer in the world, is simply writing letters to hospitals and physicians saying, you're billing too many level 5s, send us hundreds of thousands of dollars in overpayments. Just making up the numbers. They didn't look at any charts. They just said, you're billing too many, send us lots of money. And surprisingly, some hospitals and groups are writing the checks. There's no basis for that data, that demand, but anyway, it's happening. Even some Medicare carriers around the country are auditing more level 5s. Now, should that make us nervous? No, you don't want investigators looking into your records. But if we've done the right thing, it doesn't make me nervous at all. I know that, the payers and the auditors have to follow the money. So they're going to come look at charts that are billed at level 5s. And if I've done the right thing, I have no fear. Okay, anyway. So I want you to see that level 5 rates also vary nationally. So there's a lot of this going on in terms of coding accuracy. So like in Southern California, really this would be about 65% would be level 5s if I didn't include the critical care. because 10% of our patients in Southern California, we're billing critical care on. Okay, so if I only looked at level 1 through 5, not critical care, our level 5 rate in California would be 65%. Okay, now if you're in Maine, apparently that's where you should go to retire, because nobody's sick in Maine. 24% of the patients get level 5s. Is that like Mainers are tough and they just don't get sick, or is that a coding variation? Well, in fact, almost every emergency group in the state of Maine is hospital employed, and the hospitals historically have coded simply matching what the facility reported. So they've never really attempted to code, by Medicare guidelines for physician services. It's just that was the nature of healthcare in Maine for years. So that number is now changing, but this was 2010. So just to say, there are anomalies out there. Okay. Critical care. Like I said, I think 10 to 12% of average Medicare patients get critical care. The data shows that it works out to about 7%. I'm not going to talk about that, but critical care rates. We're going to talk more about critical care and observation this afternoon. We're going to do evaluation and management this morning, but critical care and OBS are two commonly performed emergency physician services that get underreported. Often because we don't know what is ED OBS. We think of OBS as, rightfully, CDU work, right? Send a patient to the CDU. That's OBS care. But there's a whole lot of observation care that we do in the emergency department that we don't report because we don't recognize it. And even worse, once we recognize it, we're not quite sure how to document it as real emergency department OBS. So we're going to talk about that. I'm not going to spend a lot of time. Do you have a CDU that the emergency physicians are staffing? Okay, all right, good. Is there a CDU in the hospital that you admit to?
It's more of a virtual observation.
It's virtual, okay. And for diagnosis-specific patients, I assume?
Yes.
Yeah, like CHFs or yeah, right, okay, all right. Okay, well, we're going to talk about observation and critical care. Spend a little time on that this afternoon. Just some quick background payment policy stuff. I want you to see, when we're talking about evaluation and management this morning, I want you to see the payment difference from the different visit levels. Because when we talk about down coding, what does that mean? When I say down coding, it means the case that you worked up deserved a level 4, let's say. But the way it got documented only allows the coders to report it as a 3. Okay? That's down coding. Deserved a 4, got down coded to a 3. What does it cost the payment system? Okay? Well, if there's a patient that's a level 5, let's say the chest pain, progressive, I gotta go to I gotta manage the pain, excuse me, IV, probably critical care on that patient, but I failed to document critical care. I lose 29% of the RVU value. I have to downcode that chart to a level 5. If it's a 5 that I happen to forget the finishing statement on the system review, it's a chest pain, it's not critical care, but it's a chest pain, I do a full workup. We're going to admit them, but I failed to document the system review on that. Goes from a 5 to a 4. But notice the biggest payment loss in terms of percentage is the level 4 that becomes a 3. What are those? And those are tons of patients that we see. Flus, fevers, low back pains. These are patients that have a differential that includes some concerning stuff, not on presentation life-threatening, not clear they've got the guy's got raging meningitis, but it's part of your differential that you're worried about. These cases deserve level 4, but we fail to document the differentials on those. those 4s become 3s. So get them a script and get them out the door, that 4 becomes a 3. Loss of 89% RVU value. That's almost like seeing an entire new patient, like an ankle sprain. Yeah, you can do those pretty quick. But it's like seeing an ankle sprain, going in at Epic, documenting the whole thing, getting the pain med ordered, go back and check the splint after it gets put on, It's like doing all that work and then throwing it away because we failed to comment on the differential on that patient that would have turned that 3 to a 4. It has almost the same RVU loss. See, that's 1.6 RVUs lost right there. That's like seeing another low-level patient. So I want you to understand how the downcoding affects the bottom line. Those are the dollar values for 2012 nationwide. Wisconsin's a little less. The payment amounts are a little lower here than they are nationwide, but just so you get an idea, level 5's worth somewhere around $160, $170. Critical care is up over $200 in Medicare dollars. In commercial dollars, it's going to be probably 2 to 3 times that. Medicare normally reimburses about 1/3 of what your charges would be, or what your recognized charges would be from a commercial insurer. Okay, so a lost critical care, it's going to be around $600, potentially. $550, somewhere in there. Okay, just some background. In 2012, we lost, because of RVU changes, we lost a little bit in total payments. The specialty did. Not much, 0.8%. I'm not going to get into the SGR, the whole what will happen in sequestration. There's an issue with how Medicare payment's going to go forward in 2013. It's a budget problem. It's going to take Congress acting on the budget before they leave. In a lame duck Congress, how are they going to act? Because nothing will happen with the budget for 2013 until after the election. Congress is gone. They're off. Doing their election thing. They're campaigning, so they're gone, and they won't come back until after the election. And then, depending on what the House and the Senate look like in the new, for 2013, it's there's no way to know. Anybody who's telling you what's going to happen to the Medicare money in 2013, is making it up. There's no way we can know. But we do know that there is a potential for a great cliff, about a 29% drop-off in reimbursement, given certain things. That's already built into the system, that unless Congress acts in a particular way, there's a 29% cut that will happen to all physicians. Congress has always acted to avert that. It is considered to be, to some, an economic disaster for healthcare, but we'll see. We'll see how Congress plays out. At any rate, okay, enough said. Real quick, we'll talk more about this a little later. Changes to observation care, not relevant to the physicians. It's really only a coding issue, and we'll talk about it in the obs care section. But basically, the only thing that happened is observation care now has an average time. Unlike before, we didn't have any average times for obs care, and you know how you can code an inpatient visit based on average times? You can do the same now for observation care based on 30, 50, and 70 minutes of time spent with a patient. Prolonged care is now in play with obs codes. Separate discussion. It's very, that's minimal impact to emergency coding. One thing to be sure that we are recognizing, it's a coding issue. Coders, how are you handling patients who come back for suture removals? Do we code them for professional component now? Anybody know?
No, the sutures were placed here.
Sutures are placed here.
They're removed here. There is no charge.
There is no charge. All right. Is there no facility charge either?
There's no facility.
Okay. Medicare removed the reimbursement for, in the past, you got paid on the professional side for the removal of the suture when you placed it. 2 years ago, Medicare pulled that money out, reduced suture placement, reduced payments for suturing by half. Okay, they went from, there's the example, a 12001, your smallest laceration repair, used to pay $102, and last year it got dropped to $55. Why? Because Medicare said, well, we know those patients are going to come back to you anyway, and you're probably going to bill them. So we're just going to reduce the payment, and now you can bill them. Now you should bill them, because we think you've always been doing that anyway. Well, we haven't. No one was. But that was Medicare logic to say, if you want to get paid for the full value of placing and removing, now you get bill Medicare for placing, and then you bill them the second when they come back for removing. So it's a payment difference. Now, yeah, it's got patient complaint issues, and it even has risk management issues, because you'd like to tell the patient, come on back here. Just let me check. You don't want the gunky wound going to the primary care guy who looks at it and says, oh my God, this thing's a mess. You want them coming back here, right? So, set your policy however you'd like. I just want you to know that for Medicare patients, I wouldn't say most, maybe the majority of emergency physician groups out there and hospitals are now billing for the return for suture removal, the routine follow-up care, because Medicare stopped paying for it.
What about wound checks?
Same thing, wound check, yep. Come back in 8 days, let me look at it. If it looks okay, we'll take it out, that kind of thing.
I'm talking like 24-hour or 48-hour.
Same issue. Those are not paid for in the initial, okay? But again, there may be good risk management and sort of public relations reasons not to do that. So I'm not telling you, hey, just start coding for that stuff. I'm putting it on the table saying it was a significant loss in reimbursement to emergency medicine, cut our LAC repairs in half, and that is, LAC repairs are the number one procedural thing we do, beyond the evaluation of management. It's like 10% of our patients, we're doing LAC repairs on. Now we just got that money cut in half. How do we recover it? Well, bill the follow-up, bill the the removals and the.
Just typically removals, physicians don't see them.
Don't even see them, really? Okay.
Not the register, to be honest.
That's a good point. Right. Okay, they may not even be registered.
I mean,
Okay. I imagine they'd get registered, because triage has got to look at it, right? No, they don't? They don't do a vital check and make sure there's no medical emergency and all that stuff?
I don't think so.
Huh.
Well,
Okay.
they can put in Epic, their name shows up.
They do show up. All right. Okay.
I don't believe that they are getting vital signs taken or any sort of
Okay.
evaluation.
Okay. Okay. It's fine.
It's not the same.
It's fine. Yeah. Just. Okay. Smoking cessation. Are we trying to bill that here? Okay. You're aware we can now bill that not related to any medical condition the patient has. It used to be talking about smoking, say, hey, quit smoking because you got CHF, okay, and it's not good for you. Or you got COPD, and that's really not good for you. Now, patient says, hey, I'm a smoker and I'd like to quit. Good idea. Doesn't matter what condition you got. You're the white coat. You're telling them to, hey, stop the smoking. That now that qualifies. You can bill for that no matter what the diagnosis is. Because, it does take, it takes 3 minutes of conversation. Just saying, hey, watch this video, or talk to the nurse, or hey, that's not a good idea. You really should cut that out. It's really, it's emergency medicine. We kind of make light of this a little bit, but studies have shown over and over and over again, the white coat effect is amazing. And even in emergency medicine, where you don't have long-term contact with the patient, the fact that you told them to stop smoking, and you actually sat down with them and looked them in the eye and said, this really is, you'd be much better off. And you spent 3 minutes with them. The science is there to say, wow, that really makes a difference. Now, do we have that kind of time is the question. Probably not most of the time. So I'm not saying, hey, make sure you spend 3 minutes with every patient telling them to stop smoking. I'm not saying that at all.
What does it pay?
It pays twice what an EKG pays. It pays like $15, $16. I mean, it's so surprising for 3 minutes of work. It's a surprising amount of money. So all I'm saying is I know that you have these conversations sometimes with some patients. Okay? Now, you just sort of end up getting in because they have lots of questions, and you just end up getting in. When that happens, document, but you have to state that there were at least 3 minutes of conversation. 3 to 5 minutes discussed, need to stop smoking. Done. But I need some kind of time statement from you. That's all. Okay, we can, benchmarking, not a big issue.
Can I ask our billers, if we do that, are you guys gonna bill for that? Are you actually gonna do that?
If we document it,
Yeah.
yes.
I bet you would, yeah.
Yeah,
Right.
I've seen it when I look at reimbursements. I see it billed all.
Oh, good,
Is
good,
that
cool.
a procedure
Nice.
that
With
we,
the ER?
yeah. How do you look,
No, I
just in the
can't see
narrative, you look for
ER,
that?
yeah. in
Narrative,
general.
discuss smoking sensation greater than 3 minutes or 3 to 5 minutes.
Yeah, it's just a statement of, estimating your time.
Well, I'm just wondering with the volume of narrative you have to read. That's what I'm saying.
Well, you don't have to read much.
Just making it down.
You don't have to write much. Yeah. Okay. It's out there, It's out there.
This time next year, nobody in Janesville will be smoking.
Okay. I don't know. Do you want to talk about rack audits? You guys been through them? Yeah, hospital knows. You guys know about rack audits. Physicians, bottom line is, don't worry about it. Seriously, don't worry about it. Because the only stuff that the racks are allowed to look for are things that are really egregious. Things that, like billing wrong body parts and, gender-specific conflicts and, things like, it's not really a big worry, quite frankly. These are the collection agencies for Congress. They're the guys who are paid a percentage of whatever they can collect in getting hospitals and physicians to pay money back. Okay, but it was such a onerous sounding program that they put in enough constraints on the collection agencies, the MAC contractors, that it's really not a big deal. They have to show that you're really up to something before they can even begin to look at your own charts. So I'm not worried. All the rack audits, and we get them all the time. They're for confusions. They're things like the patient came back after they'd had like a suture. They had a suture. They came back 4 days later with abdominal pain. It didn't have anything to do with the suture. If it did, it was, back in the day, it was bundled 3-4 years ago, so the rack auditor will look at that and say, oh, they came back in the post-surgical period, so, hey, we want our money back for that level 4 abdominal pain patient that we paid you for. And, we just show them a copy of the chart, and they say, okay, never mind. It's that kind of stuff. Okay, it's again, not worrisome. ASAP made such a big deal out of this, and it was like, no. There's a lot of constraint put on the rack auditors for what they're allowed to review and so forth. ICD-10 and 5010 transaction update. It is going forward. We have our drop dead date. Okay, yeah, we got a year delay, but it's going to happen. Now, I'm one who says this is not a bad thing for healthcare. That's my perspective, and I don't think that it's going to mean that physicians, you're going to end up having to write a whole lot more of unimportant stuff. I don't think that's true. What it will mean is your coders are going to be a little smarter. They're going to have to learn a whole bunch of additional stuff, language, and how to translate, right? But for the physicians, all it means is we need to write down what we should always have been writing down, like which bone is it? Okay, tell me that it's a finger fracture, right? There are a number of, give me the anatomically precise location, please. Okay, kind of like a good idea. Tell me if it's the distal phalanges, that'd be really nice to know. Or if it's the metacarpal, I'd kind of like to know that. All right, that's stuff that makes a difference today, right? It'll make a difference in 5010. I mean, in ICD-10. there'll be some other subtleties that will, so we're not going to ask you to write more. We're just going to ask you to be a little more specific and precise. So I don't know what you guys feeling. Am I stepping on any toes here? Or are you like asking them to do a whole bunch of hoop jumping or anything? Okay. I didn't think so. I didn't think so. So I'm not really worried about it. All right. It's a system issue. It's far more, and I think it's going to be more precise. It might actually allow payers to get a little picky about what they will, with medical necessity things about, should you have ordered that test or not. Yeah, it'll give payers a little more ammunition. But precision is better than imprecision, in my opinion. You're more likely to be right when you're precise. So here's an example. It's a displaced closed fracture, distal failings to the left fifth. Okay, that's if the fracture is displaced. If it's non-displaced, we should say that. Okay. If it's closed, if it's an open fracture, we should say that, right? Kind of like that's a good risk management thing to say. Distal failings of the left fifth. Okay, that's a reasonable request for describing the fracture. So we're just going to code it very differently. Under ICD-9, it was coded that way. The only thing that was distinct was not under ICD-9. It didn't matter whether we called it displaced or closed. It's just a fracture. The bone was the distal phalanx, and it was closed. I'm sorry, yeah. So it wasn't questioned about whether it was displaced. Under ICD-10, it'll be much more precise. There's a section here where we'll learn that it's a displaced fracture of the distal. The left little finger there, the seventh digit, and then it's an initial encounter for initial closed fracture. And I think in some ways this is going to make it more clear to the payer, hey, I was the first one to treat the orthopod that comes along later wants $600 for, taking off the splint that I put on and putting another one on just like it, and he wants $600 for that. I did that first. I kind of like, I like that, it's not a modifier, the A digit says, we did the initial encounter of the fracture management here. That's why I want my half of whatever the orthopod, would have charged, because, we don't charge their rates. But anyway.
That does make a difference, because right now, in Epic, you have to have an ICD diagnosis.
What, are you doing the diagnosis coding?
Because it has to match up with an ICD-9 code, or diagnosis in Epic.
Really?
They're choosing off the list.
They're choosing the, oh, that's right. God, I hate that.
So.
Yeah. Oh, man, you guys are not diagnosis
When
coders.
that goes to ICD-10.
10, yeah.
That makes, I don't know what the Epic's going to look like.
Oh, it will, yeah, it'll accommodate. Yeah. Oh, yeah, now you got, yeah, I went from here to, no, I don't know. I don't know how it'll work.
Well,
But anyway.
we don't know yet either because we don't have it in place yet.
Yeah. Electronic prescribing, big issues made of this, doesn't pertain to emergency medicine, because basically we don't control how the hospital controls, we don't control how the prescription gets to the pharmacy electronically or on paper. Not an issue for us, so we're not qualified for reimbursement there. X-ray EKG policy, I'm not going to go into that now. It's a coding controversy. Do you code for EKGs? For your initial EKG?
ChargeMaster picks that up, I believe.
It does. So it reports it as a professional. Is there a professional component, or does that get billed by cardiology or the reader panel? Or
We're not picking up ER physician services for EKGs.
for EKGs? Okay. All right. It is more common to do that. That's uncommon. There are issues with contemporaneous interpretation and so forth. There's a bit of policy that goes behind that. But one thing is clear. Now, the payers have made clear that they want the They want the providers to report the actual date when the interpretation was done. So if your reader panel, I don't know if they're the cardiologists or internists or a select, number of physicians who read EKGs after you, if they do that the next day, they're supposed to report the EKG for the day they interpreted it. Now, you're going to interpret the day the strip was done because that's when the patient was sitting there in front of you, and that's your interpretation date. Under current Medicare policy, both EKGs would be billed and they would be paid for. Medicare says they don't want to pay for both, but they can't prevent it. Because specifically, the aftercare interpreters should be reporting their own data service. It'll be different than yours. Both will end up getting paid. It's an anomaly in the system, but it's basically what I'm saying is you're not going to take money out of somebody else's pocket. Most often, you're not, if they're not reading the same day you are. Ultrasounds, are we billing any bedside ultrasounds?
We're getting there.
Are we? Okay. There's a common one, the 93308, 26 modifier. It's a follow-up or limited study. This was a change in 2009, but it made it real clear that our bedside ultrasound. Now, American College of Cardiology didn't like that. They thought they ought to own this. So did radiology. And I was at the CPT symposium when they sort of said from the dais that we think that when emergency physicians do echocardiography, that it's really part of the physical exam. And I was one of the guys who went up to the microphone and said, and describe to me why when you do it, it's not, but when we do it, it is. And they couldn't, it was, and Medicare was there, and they said, we're not going to differentiate. We're not going to pay cardiology because they're the specialists and not pay the emergency physicians. So, bottom line is, Medicare says, we get it. If you do a separate report, just like a cardiologist would do, you're going to dictate, okay, here's my ultrasound, echocardiography, the heart reveals, appropriate wall motion and no pericardial fluid. That's a limited study of the heart. Doesn't try to, document everything about the heart. It's a limited or a follow-up, same thing, limited or follow-up study. Okay? Two comments in a separate paragraph, and you're done. That's appropriate reimbursement. That's appropriate documentation to be reimbursed for bedside ultrasound. Rhythm strips, are we reporting those? That's an opportunity because the reason I put it up here is that it's a coding confusion. It's been a coding confusion for a while when CPT changed back in 2008. A lot of people read this and said, well, triggered by an event, rhythm strip is used to help diagnose. What all we do is look at the telemetry monitor. We float through the department. We kind of look up on the monitor. Oh yeah, patient looks fine. Look at their rhythm and look at their rate and say, okay, it's fine. But if a strip is when does that happen? If a patient has a run of VTAC or something, or strips are printed from time to time, and you're going to look at them to document a particular change after a med, for instance. Do we want to document that the rate came down? We got the rate down after the cardizem, right? So we're gonna get the strip and we're gonna look at it and say, okay, the rate's now 114. All you have to document is that the rhythm strip showed that the rate was 114. What that says is a strip was printed and I interpreted. I didn't just look up at the monitor as I'm flying around the department. A strip is printed, it is documented, it is kept in the record. Epic captures that stuff, so you don't even have to have a physical piece of paper. You have to have an electronic capture of that reading at that time, and you say the rhythm strip shows, pays almost as much as an EKG. And you may end up doing 2 or 3 or 4 of those on a patient over an 8-hour stay, as you're managing their arrhythmia, before or after an event, like an intervention to a med, right? So we do the initial EKG, and then, there's a change in the patient's rhythm, and so now it's going up, and the strip gets printed. You document that. We get them on cardizem. The rate starts to go down. You document that. I've now got an initial EKG plus 2 rhythm strips. All of those are separately reportable. Just have to document them that way. Okay?
Are you going to talk later on about our documentation of EKGs?
Yes, I am. Okay, so that's just kind of the background stuff. Questions or issues for what we've got so far?
I think, well, I don't know, I don't speak for anybody, but I usually don't use rhythm strips. I do another EKG.
Okay, all right, well, it's just fine. That's fine. We can bill multiple EKGs as well. I will point out, though, that if the hospital is hesitant about billing EKGs because they want to defer to the reader panel, it's a political issue. It's the reader panel. It's the hospital giving an exclusive business franchise to somebody else. It's free money. It's like, here, do we really need, the cardiologist rereading your EKGs? How many times they say to you, that EKG I looked at from last night, right? I came in at 7 this morning, and I was so interested to learn about that patient you sent to the cath lab already, right? That I looked at your EKG, and I'm not sure whether... You ever get that? Of course not. Absolutely not. It's a bogus business franchise.
So what do we do?
So, but I'm saying that politically, the hospital often grants that franchise to someone else. Yeah.
What do we do?
I think our pediatric EKGs get sent out, because I have been called a couple of times by UW.
Oh, cool.
Regarding abnormal pediatric EKGs and need for follow-up. It's been a rare occasion, but I know at least our pediatric EKGs.
That's a good point. Peds EKGs are a little tricky.
Yeah.
Yeah.
But I don't know what to do.
Well, they are all reviewed by another cardiologist at a later date.
Why do that? But I mean,
I don't believe there's been any decision made as to it's their exclusive right, so technically we both can afford.
But the question says, what do we do?
We're not currently.
Not currently billing. That's what I'm saying. You're doing the EKGs, right? Okay, fine. Hospital's not getting paid for that. Bill the rhythm strip. Cardiology's not billing the rhythm strips, I assure you. Okay, those you can get paid for.
Right, see, that's my point. Is that we're not,
I know.
I'm
You're right.
thinking we're getting billed for the EKGs and we convert somebody. But
Correct.
If we're not, that's something to ask. Are we not doing?
Mercy is, but I don't believe the ED itself is.
So then we should be doing the rhythm strips in addition to EKGs so we can actually get billed for that.
Well, we've identified a couple issues. One is actually coding and billing for them, and the other is our adequate documentation so that they can code and bill for it. And we're missing on both levels.
Okay. Okay. So commenting on the strip.
So we should be doing
Okay.
strips.
Because that's that's the key
We
thing.
can get the EKGs,
As long as the documentation's.
but we've got to get our documentation.
Oh, good.
I think there's
Sweet.
a phrase in Epic
Good.
that will cover all required. If you type in .ekg, they'll bring in a smart phrase where there's wildcards where you can hit F2. This is a sinus rhythm, left axis.
Or you can just say it though too.
You can just say it too, but I'm just saying.
Rhythm rate 68.
Oh, do you have Dragon? Do you use Dragon in your? Oh, nice. Is it working okay?
Depends.
No, I know. Yeah.
Understand me. I type everything.
Yeah.
I type everything.
I do hear variable. I have some groups who use Dragon with Epic, and it's like, oh, it works great. And other groups say, that's a mess. It takes more time. I could two-finger type it faster than I can make all the corrections. So I never know whether,
Anti-dragon.
it just doesn't like it. Okay. Other questions before we move on? E&M?
We either be some sort of
Okay, we're on to evaluation and management. This is the heart of revenue and emergency department. It can be 80% of the total cash generated for the professional component. Evaluation and management. So this is where we're going to spend the bulk of our time. We already talked about this, but communicating the value is the heart of documenting the medical decision-making process. Now, template troubles. I mentioned the article in the New York Times, and really you should take a look at it. It's going around the emergency medicine world. You'll be able to, probably if you just Googled EHR, New York Times article or something like that, you'll probably get access to it. But here's what Medicare says about the use of macros, the dot phrases in Epic. The physician may use a macro, all right? So let's start out with yes, you can. Yes, you can. And I think there's a value to macros because they can standardize. They can make the data entry faster. Okay, well, let's just not be the most expensive data entry operators in the world. Let's be fast and efficient about how we do the data entry, and they can standardize. So they can bring in a whole bunch of stuff that we can look at and say, oh yeah, I guess I should have done all that. Yeah, you're right. That's one of the values of the macro. Okay, so we can use a macro as the required personal documentation if he or she personally adds it in a secured or password or protected system, and the macro provides customized information that is sufficient to support a medical necessity determination. The note in the record must sufficiently describe specific services to the specific patient on the specific date. So we can't have every record looking like every other, or say having every chest pain patient look like every other chest pain patient. Specific information, specific patient, specific day. Some examples from Epic that don't work. All right, this is one of my early adopters of Epic. This was 4 or 5 years ago. Statements like, if the patient is being admitted, why is that in the electronic record? As my coder wrote on the chart, this particular this physician, she should know if the patient is admitted or not as part of the MDM. It's like, all right, coder, calm down. Yeah, but the point is, making policy statements part of the electronic record is just a bad use of the record. Okay, if we want to make a policy statement that says if the patient is admitted, I always do this. Okay, write a policy. Okay, put it in a memo, but don't put it in the electronic record because the if statements raise questions by the reviewer about, well, let me see some of this other stuff. Do you also mean if this, then that? It's just not an appropriate place in the record. Now, worse, here's the same neuro on every patient. Now, in this case, not just every patient who needs a neuro, on every patient. Okay? Neurologic, physiologic, no cranial nerve defect, really? You didn't do that on every patient. Okay? Now, I doubt you did all of that on every patient who got a neuro. Okay, let's start there. Same thing with the pulse ox. So here's a pulse ox statement on every patient. Okay, this is a liability because it raises the question: really, did you do way more than you needed to on every patient? Because if in a risk management situation, here. So let's take that neuro and apply it to this particular chart. Here's a patient, baseline is left facial droop, fatigue, Parkinson's, and then here comes my neuro. Flat out misrepresentation, no facial asymmetry at rest or with movement. Now, if I'm the plaintiff's attorney, I'm asking, and doctor, tell me what else you lied about in this record. Well, we just don't want to be there. That's unprofessional at best. It's a flat-out misrepresentation. We know those are inconsistent. Okay, so this is just a plea to we gotta we got to make Epic work for us. But the record's got to make sense. Now, coders, if we see this, what do we do with that chart? Does it go back? Okay, because I'm going to suggest that. I know that means a lot of extra work for you guys. I don't know how your process is for, reopening the record and pushing it back to the physician and noting, and, there's all kind of mechanical stuff for that. Okay, right. But I'm going to ask that be done because it is a risk management issue. Now, technically, we could code with that inconsistency in the record. We can ignore stuff that doesn't make sense. But I'm suggesting that it's a liability. And the physician needs that feedback because they may not know. How many times is that happening? I know I'm doing that. 2 in the morning, I'm not reading everything that Epic spits out. I'm racing to keep up. I'm tired, and, it happens. Stuff happens. So, but you want to build your record in a way that templates the stuff and wildcards what needs to be wildcarded, templates the stuff that you can reasonably argue you've done every time. I think that makes sense. We know there's certain things we always do for every patient, and that's fine. Okay? But you got to be able to make it specific to that patient on that day. Now, that's why I'm an advocate of dictation in combination with, whether it's dragon speech or actual dictation, or if you're going to do the typing thing. Here, and you know the reason. For the record to really be, you want the record to be evocative of your encounter with the patient. You want it to bring back to you, in your own words, what you actually saw and thought at the time. Because if you got to sit on the defense stand 4 years from now, reading that record, you want to be able to recall that patient. Now, you're not going to recall everything about the patient, but if you're using your language, that's language that you're safe and comfortable with. You can defend. If you're using the system's language, relying on it, believe me, you're going to stumble on the stand. It's just, you're trying to defend somebody else's word. But if those are your words, you know how you chose them, you know why, and you use very specific language, particularly in the HPI and in the medical decision making. The ED course you can kind of flow with. It's like, okay, we started with this med and you got them that, and then the rate went down, so I took them off that, and then I started this. ED course you can kind of flow with checkboxes. But that section where you talk about why you did what you did, that's medical decision making. That section, I think, needs to be, that's dragon speech, that's free text, that's typing. The same thing with the HPI. How that patient presented needs to be your language. We're going to talk more about this from a reimbursement perspective and why that's important, because I want to get all the risk management issues into the presenting problem. But anyway, okay, so more template troubles. This patient, I just put this up here, but this patient arrived at 11:10, got a single EKG, a glucose stick, 2 blood pressures documented in the 130s, okay, not bad. There were times in my life I wish I would have had pressures only in the 130s. One at 119, another 11:46, out the door in an hour and 10 minutes, okay? This was their complete workup. Saying that medical decision-making is high doesn't make it true. So here's the Epic statement. Medical decision-making is high and complex, requires critical thinking. Hypertension may be emergent, severe, and urgent, requiring rapid intervention. Why are you telling me this about a patient who had 2 pressures in the 130s? Right? What am I trying to do here? It just makes you suspicious of that record, right? So, clearly we're not going there. We're not going to try to make the patient look sicker than they really are.
Cardiovascular, genetic, malignant, toxic.
Oh, yeah. Oh, yeah. Well, look, we got cardiovascular, genetic, yeah, right. Mike, Exactly. So, hey, I'd worry about this patient, okay? But not on this, not on that presenting problem. So you get the idea. Let's make the record real and honest and So here's a kid comes in, brought, from the pediatrician's office. X-ray showed a fracture of the upper extremity. They were unable to obtain an appointment for orthopedics, and therefore presented here for evaluation. This is what, 1 day or 2 days post-diagnosis by another physician. Pediatrician diagnosed from the X-ray, diagnosed the fracture. Couldn't get in to see orthopedics, so they brought the kid to the emergency department. So, any arm pain and complex medical decision-making due to multiple differential diagnoses, ranging to critical cardiac to the common musculoskeletal, could be cardiac, could be strain, could be tendonitis, joint syndrome. Come on. So my point is, saying that that's true doesn't make it true. Don't try to make the record say more than the encounter actually reflects. Because this sort of templating is that's what Medicare's upset about. That's what they don't want to see happen. Make it patient specific. Now, Medic, do you use scribes? Huh? You do? Not in the ED.
But in other areas.
Yeah. How'd that happen? You guys just not want them?
Yeah, I'm curious who uses them.
Or do you guys have one?
No, I was curious who uses Scribe in the system.
No, not going
It's a common, partly because of the template issues. A good scribe service can speed through the stuff and can eliminate some of the junk. They can. They can make you more efficient. By understanding Epic well, that takes time, takes training. The rise of scribe services has paralleled the rise of EMRs in emergency medicine because of this very need. Hospitals need enterprise-wide reporting of medical care. The electronic medical record has been forever getting to healthcare, and it's the number one thing that has a potential, okay, if it's done right, potential to reduce the cost of care, because we can reduce it across the entire continuum. It's really cool what happens, when a patient is seen in another Epic hospital 1,000 miles away, and you can get the record instantly in your emergency department. Stuff like that is really, it's so sensible, and it's taken so long for us to get there. So tremendous value, but it has tremendous operational issues associated with it, and reimbursement issues, quite frankly.
We struggle with, so even though we may use them, we may not use them well.
Yeah. So that's all to say that scribes have it now. Anyway, I won't go into it anymore, except to say that it is an option. Medicare recognizes the value of the scribe. They've even specifically described what a scribe must do when they enter notes in a record. They must actually sign. They must indicate they have scribed for. They may only be human tape recorders. They cannot be providers. They can't ask questions on their own. They have a status even below the janitor, who effectively could ask questions of the patient independently, fill out a little sheet and hand it to the physician. A scribe is specifically precluded from doing that. Okay? A scribe cannot be an independent sourcer of information. They may only be your human tape recorder. You may ask the questions, they write it down. Now, they can ask you to go back or say, hey, did you ask them about? Because they're filling out the record and they're realizing, oh, I don't have enough system review here. Or, this patient, like on the critical care list, but you didn't mention critical care. They can help with that sort of thing. But they can only do, enough to record what you're doing. So, scribes are valuable. They just have to be managed in a particular way, and you can't have them doing independent care. That's a liability. Okay, on to the heart of evaluation and management. These are the sort of the 6 things that we'll focus on in our time this morning. The HPI system review. Not going to talk much about this. The social history, not hard to get them. About innate organs in the physical exam. It's really easy to document that too. Critical care obs. We're going to talk about documentation of those 2 things. So those are kind of the key points. Okay. Now, when I talked about down coding before, here's what happens. A patient presents with a medical decision making with an underlying potential problem that we score as high. Example, the chest pain patient with shortness of breath. And when I go to do the physical exam, I do a comprehensive head to toe, 8 organs in the physical exam. But when I document the history, I fail to document a comprehensive because, let's say I missed the system review. Well, the comprehensive exam, we'll learn in a minute, requires a 10-organ system review. So if I've failed to document 10 organs, that becomes a detailed history. And the principal rule of evaluation and management coding is that I must code to the level that equals all 3, equals or exceeds all 3 components. So a high decision-making, comprehensive exam, but detailed history requires that I code at the level 4 rate. Now, that makes sense in a way. If I didn't do all the work of a level 5, why should the payer pay for an entire level 5, right? And the work is frankly not that onerous. So, so this is what happens in downcoding. Now, one of the most expensive problems we have, the patient that's very familiar to you, in the old days of transcription, we'd say, okay, this is a COPD, well known to me, short of breath, 2 days, no nausea, vomiting, diaphoresis, and now I'm on to the, to the rest of the physical exam. Because I know this guy, right? And I know what we're going to do for him. But and usually we can get him out the door. It's like his 5th visit this month. But this time he's not clearing. He's really tight and he's wheezing, and I'm probably going to have to get him in the house. But my system review, my HPI just shorted the complexity of his presentation this time. All I said was COPD, short of breath, 2 days. So now that deservedly level 5, we'll learn in a minute, with an insufficient HPI becomes an expanded problem-focused history. Now I have to downcode all the way to a 3. So the HPI is the one that we end up losing sometimes some significant amount of money. Okay, we already talked about this slide. Now let's talk a little bit about diagnosis coding. Coders, you know about diagnosis coding and where you can go in the record to find the ICD-9s that will support the emergency visit level. Now we're coding on outpatients. We're coding, the diagnosis codes for the emergency physicians as well as for the facility. Sometimes they will be different, meaning on the facility we may be pulling out diagnosis codes that will support the CT and some of the labs and so forth, right? But I want also diagnosis codes that will support the physician's visit level. So I may pull diagnosis codes from any part of the ED chart. In emergency medicine, use of diagnosis codes is commonly presenting problem focused, not final diagnosis focused. Because why the patient presented is often, in emergency medicine, more important than what we concluded. The complexity is in their presentation, not in their final diagnosis. So I suggest to ED coders on the pro-fee side that we be willing to look elsewhere in the record outside the final diagnosis block in order to identify, either from the system review or from the HPI or even in the differential diagnoses, possible, not really in the differential diagnosis, but in the medical decision-making section, possible diagnosis codes that will support the visit level. For example, if I have, these are diagnoses that insurance companies consider to be of low severity and not worthy of emergency department care. A URI. Well, URI, kind of like what I've got. I got a cold for the last couple of days. So I'm turning a rough voice. But, so do I need emergency care for that? Well, heavens no. But if the patient presented short of breath, that's a different problem. Now I work it up and I conclude finally, it's probably a viral. It's probably just a URI. It'll clear. You'll be fine. Patient didn't know that, and frankly, you didn't know that on initial encounter until you got to you got to work on it a little bit, right? So that while the presenting problem is shortness of breath, that's the diagnosis code that would support the potential level 4, maybe only a level 3, but if the patient had some fever and some other concerning signs, it might end up being a 4. I would want to support a level 4 with shortness of breath, a more severe diagnosis code than, say, URI, which would be the final diagnosis code. As an example, a 47-year-old chest pain undergoes evaluation with an EKG, chest x-ray, cardiac enzymes, gets a GI cocktail with a final diagnosis of gastric reflux. Now, physicians, I'm going to suggest that you help the coders here by putting in the diagnosis area the concerning signs and symptoms as well as your final diagnosis. Now, I think I can make an argument that the final diagnosis here, GERD, is immaterial to the patient's workup. We like to be conclusive. Okay, you're doctors. You're the smart people. Okay, you're supposed to conclude. You're supposed to come to a conclusion, right? But in emergency medicine, frankly, we can't be all that certain that it's GERD, right? I really need to see this guy over time to kind of watch what happens here. Check his chest pain and stuff. I'm pretty comfortable that it's GERD, but I don't know that for absolutely certain. I've only had 3 hours with a guy. I got a couple of enzymes. I know he's probably not having an MI right now, but to be absolutely sure it's GERD, maybe. Your gut will tell you, yeah, probably. But my point is that you can help the coders paint the picture by identifying chest pain as your primary diagnosis because it's the more severe presenting problem. It's the reason why you did all that work. Okay? Now, that should give the coders the ability, the opportunity, to code chest pain as your diagnosis code along with the evaluation and management. Okay? So sequencing, physicians, you can help the coders by sequencing your diagnosis codes in order of severity. So, gastroenteritis, let's talk about acute abdominal pain, right lower quadrant. Okay? It helps the coders pick up the diagnosis code that will better support the visit level that you're going to code for. I mean, that abdominal pain with a CT, CBC, rule out an evaluation for appendicitis, maybe the CT came back negative, but the guy's still in writhing pain, you're not going to send him home for hours. I mean, this guy could be here for a long time. Could well be a level 5. I want to send a level 5 out with gastroenteritis? Well, that's kind of your working diagnosis, but are you absolutely sure that there is no disease process going on in the abdomen? I'm pretty comfortable. That's why I'm letting him go home. But I'm not 100%, don't shoot me if it's not a gastroenteritis here. So that's what I'm saying, is build some support for the coders to get the diagnosis codes on the signs and symptoms, not just the final diagnosis codes. Make sense? Fair enough? Coders, will that help you? Okay.
You're just using our diagnosis that we put in now.
Yeah, are you reading the HPIs now?
Yes.
Are you pulling out diagnosis codes from the HPI? Oh, sweet. Even better. Even better. That's great.
I just have an issue with that because the gastroenteritis is causing the abdominal pain. That's
Yeah.
how coders think. So on the MDM, we're probably just going to be giving them credit for the final diagnosis.
Well, that'd be the, okay, but that's the opposite of the way emergency medicine works.
Okay.
That's my point.
Well,
So I understand,
don't
I understand,
ER, so
no, I know, I understand how I understand how diagnosis
internal
code,
medicine and that.
I understand how diagnosis ICD-9 works.
Right.
The logic of ICD-9, I get. The problem is that the logic of ICD-9 assumes a great deal more certainty than we are allowed in emergency medicine. We don't have the time and the tools to be that certain. See my point? So that's why I'm saying, I would, if I have in the past told physicians, leave the gastroenteritis off. Doesn't help anything. Doesn't help anything. No, I said, I want to be the smart doctor. I want to say, absolutely. I said, I'm sure it's gastroenteritis, because I don't want anybody to think that I wasn't sure. I'm sure. The point is, well, you're pretty sure, but you're not absolutely sure. So I'd leave any, low acuity diagnosis code off the chart. The point is, what do I know? Guy's not dying from whatever he just presented with. That's what I know. That's what you pay me to know. That's what you want me to be smart enough to know. Okay? If it's gastroenteritis versus, irritable bowel or some other thing, frankly, that doesn't interest me. And it's really not my job. But I can tell you that he's not going to die of whatever his abdominal pain is today. So, we'll concede that in healthcare we need to come to conclusions, okay? So in deference to other providers, other physicians, who have to manage this patient as well, they would like to know your conclusion. So, okay, we'll put it in there. It'll help. But bottom line is, hold me responsible for the abdominal pain that I really don't think was lethal for this guy. That you can hold me responsible for. See my point?
Well, put something like, if I put in abdominal pain, and then my next diagnosis won't be gastroenteritis, it will be nausea.
I love that.
Well, we can.
If you're good with that, if you're okay with leaving the gastroenteritis off, I don't think gastroenteritis tells the true story of an emergent patient. That's my point. I think it confuses the issue. Payers can look at gastroenteritis as the fourth diagnosis on the claim and say, oh, well, that's a reason not to pay it as a medical emergency, because if they really only had gastroenteritis, yeah, they had all this other stuff, but they only had gastroenteritis as a final diagnosis, I don't want to pay for that. Now I'm like, just leave it off. But you guys work that out. Bottom line is, help your coder by sequencing signs and symptoms up there. And then coders, please do go look at the HPI and find those and sequence them, ahead of the lower acuity diagnosis
How can
codes.
we as ER physicians spot the higher acuity? Because I'll do something like Hale does, and for a person like this, I may put right lower quadrant abdominal pain, diarrhea, fever, nausea, vomit, and leave those 4 diagnoses on there.
They're all perfect. Those are they're presenting plans.
Like, should I have left off fever? Should I left off?
No, think about fever. Where could that go?
No, right, yeah.
Yeah, okay, fever. Could be deadly.
Even if, like, instead of using bronchitis, are you better off saying cough, fever?
Cough and fever, that's my, see, that's my point. I want you to think in terms of the diagnoses that you know to be benign, not associated with dramatic disease process. Can fever be associated with dramatic disease process? Yeah, it can. Can bronchitis be associated with a dramatic disease process? It can't. I mean, unless it's got other comorbidities, right? Okay, but standing by itself, which is how the payer makes these things look, those diagnosis codes, standing alone, if they don't present the potential for a high-risk problem, they only confuse, they don't clarify. Okay? The clarity comes with what were we managing as emergency physicians? What were we managing? We were managing to make sure that they didn't have all the other stuff. That's what we're managing.
I think
Yeah.
the issue that I have with Epic when it comes to that, and I've thought about changing things, because when I give the patient the discharge instructions, they want to know what it is. They want to see
Yeah. No, I agree.
gastroenteritis.
Exactly.
And then that populates into my chart, which is not what I want to put in there. That's one of my big issues, and I don't know if it's right or not, when it's kind of iffy, I may give them one discharge instruction, and my charts is something different on the
Yeah.
diagnosis.
Yeah. Yeah, I know.
That stuff.
That's a great point. I haven't,
I don't
yeah.
know what to do with that.
I don't know how to write discharge instructions specific to presenting problems versus final diagnoses.
Because if you don't, then they're like, oh, well, you didn't know what's wrong with me, and then they go to the clinic, and the clinic's like, well, clearly they had this, and what's wrong with this doctor?
Exactly. I get it. I get
I
it.
don't think what we select for discharge information gets, you're not.
Your clinical impression gets put on the top.
Discharge sheet.
So every one of your clinical impressions goes in at the top. If all you write is rash,
Right.
that's what's going in on
But
the
you
top.
can go and select discharge instructions irrespective.
You can't, yeah. You can't.
Their diagnosis shows up on their discharge stuff.
Right.
Right, all I'm saying is you don't have to put gastroenteritis as a diagnosis, but you can still select those discharge instructions independently and have those printed out for them.
And I do. Even if I leave their clinical impressions, it's abdominal pain.
Well, yeah, and that's a good example. There's reason to do that. There's
They
reason.
see that thing, and they say, these are your diagnoses.
And that's the first thing that's on there.
And this is what we said you have, and if it just says belly pain and non-thumb, and even if you put in the gastroenteritis, then say, I mean, I've heard them say that.
Great.
They don't know what's wrong with it. That's the part I struggle with.
Yeah.
What do you do with that?
Right, gotcha.
Well, that's a great process point. And again, driving final diagnosis issue. So here's the 10-month-old infant with 103.5. Now, if we want to conclude that URI is the cause, okay, I really want you to get in there acute febrile illness and dehydration in that record. Okay, because if you've documented it by the labs, but you didn't state it in your diagnosis area, coder may not have picked it up. You can see, just look at the CBC. Well, that's not, an unsympathetic reviewer, even if they're a clinician, an unsympathetic reviewer may say, it's not my job to interpret the labs for you. You need to tell me that you believe that this represents dehydration in this kid. So get that in the record. So I would sequence it that way: fever, dehydration, and URI, if you're going to use the URI diagnosis code. Okay. Same thing with EKGs. And your ultrasounds and X-rays. You don't bill for them, but getting specific symptoms into the system can support the medical necessity of the tests that you're doing. It'll give coders the ability to code the reason for the CT or the reason for the X-ray, so they can get those reimbursed for the hospital as well. Okay, questions about diagnosis coding? Coders, any issues? Diagnosis coding? No? Good with it? Okay. Okay, moving on. History of the history requirements. There are three components of the history recognized in the reimbursement system, but notice there are 4 levels of history. Okay, and the payment system again requires that these have to line up in order to code for a particular level. So if I want to get a comprehensive, I want to get a 99285, I better have a complete past medical and family, a complete system review, and an extended HPI. If I only have a brief HPI, this graphic shows me that I will never get past a level 3, okay, because that's the highest I can go on a brief HPI. So let's spend a few minutes talking about what are the content requirements to get an extended HPI or a complete system review or problem pertinent or extended system review. Okay. HPI, just 2 levels, brief and extended. Extended is 4 or more elements. Here are the elements. This is your PQRS from med school. Quality and severity and location and duration. So you don't have to format it this way. I don't know whether Epic requires it. Coders need to learn how to identify these elements in a record, because what we want to encourage you to do, and we'll talk more about this in a minute, is write HPIs specific to the patient's problem, because you're going to build your risk stratification out of the presenting problem. And we want to get a good patient-specific HPI with granularity, that is with detail, okay? And evocative detail. Like I said, not just all the words the patient used, but detail that we can draw conclusions. So that's why I need to know where on the body. I need to know, what was it like? What was the pain like for the patient? Don't just tell me they had chest pain. Tell me what kind. There's chest pain, and then there's chest pain. Was it crushing, shooting, stabbing? This using graphic language like that will build your, or dull, or whatever. It builds your full story. Severity, duration, timing. How long did it go on? What else was happening at the time it occurred? And then what makes it feel better or worse? You ask this all the time. On every patient, you're asking this kind of stuff. So we just want to get the specifics into the record to support the HPI. Coders, are you comfortable with picking up HPI elements? Do you ever find times when you're not able to get them from the physician? Can you think of examples, what kinds of patients or kinds of cases where there isn't enough HPI?
Every once in a while, we're in a cross record where they say HPI abdominal pain, and that is it.
Okay. Yep. Moving right along. Okay. Okay, well, all right. Oh, we know that, doctor, do we? Okay. Okay. Well, all right.
Can I ask a quick question?
Yeah, please.
In relation to this? So,
Yeah.
let's say you have a patient that's coming in with an acute MI that's already been diagnosed from the field by paramedics. There are times where my HPI will be relatively short, but I usually put something in there saying secondary to urgency. I don't have time to go over all the qualifying factors.
That's good.
And
That's a great example of a patient that you would not take time to get complete organ, 10 organs. It's actually a very good example, because one of the problems with templates is when we say that, my history was abbreviated due to treatment urgency. Let's get him to the cath lab. I don't want this guy hanging around here. Time is heart muscle. And then I add a note in there that a complete system review was otherwise unremarkable, when I've just said, for treatment urgency, I want to move this guy, and I'm not going to ask him a whole bunch of questions. That's when I don't want to click that box that says, a complete system review, or the guy that comes in comatose. And oh, by the way, a complete system review was done of all 87 organs that I could think about, and everything was absolutely negative. You don't want that in the record, right? It's because he couldn't argue with me. But that's a great point. That's great. Treatment urgency is a reason to abbreviate the history, including the HPI. But you do want to put in there anything you do get, from EMS and anything you can know about that patient.
But a chart wouldn't be down-coded secondary.
No, it should not. So long as you use the language that says, I was precluded, treatment urgency prevented me from. That and mental illness is frankly the other. And CMS says that, there are two reasons to abbreviate a history. One is treatment urgency, the other is mental status. I said mental illness, it's mental status, comatose or it could be mental illness, So anyway, HPI controversies, coders, you can take the HPI elements, you can take quality and severity and duration and all that from more than just the presenting problem. So if they've got chest pain and shortness of breath, and they tell me that the shortness of breath was for 2 days, and the chest pain was like the last time I had a heart attack, I can take the HPI elements from both of those pertinent positives, okay? Not just from the one, quote-unquote, chief complaint. It's a common misunderstanding, and I'm not quite sure why it persists in the coding world, because you have to recognize the history of the present illness is not about the chief complaint. The chief complaint is a what do we want to call it? It's like an accommodation to it's like the triage category. Okay, so we're classifying patients. Every patient has all kinds of issues, all right? But then we got to lump them into categories in order to move them through the system, and so that we can kind of classify from the provider standpoint, classify the kinds of things we're going to do. So let's call this guy a chest pain patient, okay? But he has chest pain and he also has shortness of breath. That's a constellation of presenting problems. So in the provider world, what we manage is the patient's presenting problem, not their chief complaint. Do you see the difference?
I do.
Yeah.
But you're counting, are you saying the short of breath and what was the other?
Chest pain.
Chest pain. You're counting location twice, is that what you're saying?
No, I won't count location. But I will allow to take different elements from the different pertinent positives and negatives.
Right.
So if they said, for instance, if they said I have had chest pain for 2 days and some shortness of breath, I now have a duration and a severity statement. The severity sum modifies the condition shortness of breath, right? It doesn't modify the condition chest pain, all right? But what I'm arguing is that you can take and score for both of those. I now have 2 instead of 1, because I hear over and over again coders say, oh no, it has to be about the chief complaint. But he talked about all this other stuff, but he didn't talk about the chief complaint. Okay, good. Who can take the HPI? Yeah, this is the province of only the treating provider. This is the mid-level, the physician. This cannot be done by a scribe, cannot even be done, can't take it from nursing notes. So that chart that says, here's my entire HPI abdominal pain, we can't code for all that nice stuff that nursing wrote about this patient. Okay, the HPI, I can take system review, I can take past medical, I can take social from the nursing notes, but I can't take HPI for very good reason. I don't want someone else, some other non-physician, non-provider, determining what the patient's problem is. That's the work of the physician, right? So that's why you take your own HPIs, and Medicare recognizes that and put it into the documentation requirements. Simply good medicine. So what do we do when we can't get a complete HPI? Document that. Why was it unobtainable? Due to. And then it's always good to mention where the history came from. Risk management likes that. It shows that you did a good faith effort to try to get something. The guy's corked out. It's like, okay, I guess I don't have to take a history here. Well, that's not really our attitude. It's like, I want to know more, so I'm going to talk to the family, I'm going to talk to EMS, or the police officer who found the guy down, or, going to try to get a hold of an old record, we're going to try to get something on this patient. It's, it's what you do anyway. So we need to mention that we were precluded from doing a complete history because the guy was comatose. But existing history did come from EMS, family, old record. Make sense? So the reimbursement system wants us to make a good faith effort. That's what this says. It shows a good faith effort on the part of the physician to indicate where the history came from. Okay, so that's the HPI. Remember, I need extended HPIs for both level 4 and 5. 4 elements, not hard to get. All we need is granularity and detail. That's it. Now, let's talk about the system review. Well, I need, if I'm going to do a level 4, well, if I'm going to do a level 3, all I need is the patient's problem. That's my organ reviewed. Got an ankle sprain, I got a musculoskeletal system review. That's all I need. Okay? I'll probably do a blood pressure check. I'll probably do a vital sign statement. That's a constitutional. Now I've got 2 organs. Okay? I know about your ankle sprain and I know about your vitals. So I got 2 organs on that. Okay? So I don't need much for the level 3. Level 4, I need between 2 and 9 organs. But for the level 5, I need, now that CSROU is my abbreviation. A complete system review was otherwise unremarkable. Complete system review. Not system review, however many I decided to ask about. No. I did a complete system review. I didn't ask everything about everything. So personally, I don't like the phrase, all other systems are negative, because often I won't ask about all 14, and I won't ask everything about all 14. I'd like to use language that is specific, that I did ask about up to 10 organs, because that's how many there are required. I did ask about as many as 10, beyond which I don't care, nor do I need to. The payment system only expects 10. And I'm going to document 5 or 6 of those in my pertinent positives and negatives related to the HPI. So I'm going to throw some of that system review up in the HPI where it belongs, right? And then I'll finish with the complete system review was otherwise unremarkable. Those 4 or 5 additional organs that I might ask about. Okay, so any patient that deserves a level 5 and sick enough to need one, or potentially sick, is going to get 3 or 4 or maybe 5 organs anyway. You don't just document the presenting problem and then say, and everything else was negative. Well, you ask other stuff. So let's comment on the other stuff up in the HPI or in the system review area, and then use the finishing statement.
Question about that.
Yeah.
We've run into this a little bit with Epic, because in Epic's note writer, there's the review of systems, and we can go through and click all the individual things we like.
Okay.
Populate our
Okay.
code, which I know works. But alternatively, there's just a little box up in the corner that says all systems were reviewed and negative. Now,
I would never use the phrase, I'm just giving you my, I'm okay if you do, but I could not say all systems were reviewed and negative for the simple reason that it's not true. The patient's not here because they are just fine. The patient's here because they got a problem. So the statement, all are reviewed and negative, is a non sequitur. It doesn't, doesn't compute. Anyway, go ahead.
Yeah, so we had a question from,
And that can't be changed?
well, maybe we can change it.
I'm gonna look into it.
Would you please? Because that's I can't imagine, well, I can imagine, because Epic wasn't built for this purpose, but that's really a liability. I would not want that.
But now the other thing that has come up is, can we actually does that meet the requirements of a complete review if we check that box, or do we need to say that 10 systems are reviewed?
No. If you said that a complete system review was otherwise negative, I think it would be hard to argue that you didn't do 10 organs. I mean, you can make an argument that, well, what do you mean by complete? Well, the payment system has defined complete. 10, okay? I'm telling you, I did what you told me I had to do, which was a complete system review, okay? So I did 10. I told you about 5, because, they're up in the HPI, and, in the pertinent positives and negatives, so but I don't think it would be, I don't find it reasonable to say that I have to say, and here are the 10 that I've done, and remember, I check off the one that, so, the organs are, the HPI has pertinent positives and negatives, and they're classified into organ systems, okay? Now, I may add additional ones, and you can do that, and I think it's good to have your own, like, little cheat list, your own short list of the kinds of things you want to ask about. So, you say, you get the pertinent positives and negatives, and you say, do you have any of this, or this? Boom, done. Negative. Okay, fine. Click, 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 click. And you can do that on all your patients. That works just fine. That's one approach. And I think that's even more specific, and that's fine. But my point is, I don't have a problem with making a statement that the complete system review was otherwise unremarkable, because that meets the intent of the guidelines. Question?
The exact wording of it, when you print it out at the bottom of the review systems, is all other systems reviewed and are negative.
Okay, all other systems.
So it
Good.
doesn't say all systems
Okay,
are.
that's
so
fine.
It's saying all
That's
others
fine.
that maybe you didn't make
Great.
specific changes.
Which is okay. That's Medicare's own language. I'm a little hypersensitive, so I would not check that box, because I wouldn't want to assert that I have asked everything about everything. I only want to say I did a complete.
In the systems, how many, if you go into the eye, for example,
Yeah.
how many questions within that system? Just what?
One per organ. One per organ. 10 questions. No, 4 or 5 or 6, because you've already documented why they were
You're
here.
talking about in the HPI and in that, you're talking about.
That's right. In combination, you will have asked only, 10 separate questions.
In general, are coders allowed to pull, like, so say I forgot to specifically make a review system part of my chart.
Doesn't matter.
Doesn't matter.
Format does not drive
They
content.
can pull that review system
Correct.
out of it. Because
Correct.
at this current time, it's not done that. I mean, I get chargebacks saying I forgot to review systems when all the review systems is in my HPI.
Yeah.
Oh, really? Oh, gosh.
And I'm
Okay.
Yeah, I mean, I pull review systems out of HPI. We also have a contract coding service. I try to keep track of what they're doing.
Okay.
Sometimes I'll forget
Right.
to do that part, and then, but everything is, I mean, I'm double documenting anyway, just because.
Well, that's the point. And that's why Medicare said you don't have to do that, because they don't want you to have to write the same. I mean, they specifically said you don't have to write the same thing twice.
How many elements do you have to cover within an organ system in order to satisfy it?
One.
So you can say no fever, and that's
No fever. Done. Constitutional. Yep.
Okay.
Right, because like in my HPI, a lot of times, no matter what they're saying, fevers, nausea, whatever.
Sure.
I mean, that,
So you only have to cover one element in each one of those?
Yeah.
Okay.
Yep. Yep. Pretty easy to do. Okay, so we talked about the system review. There are the 14 organs. Again, you can build your little script if you want to do it. It's really easy to get those. The finishing statement controversy has been under attack in many states, including Wisconsin. WPS, here, our local Medicare contractor, tried for a while to tell physicians that they were not allowed to use finishing statements. They didn't like finishing statements. They were preventing you from using them, but National Medicare stepped in and said, sorry, they're in the documentation guidelines, so we can't have a local carrier telling physicians they can't do something that the national guidelines specifically say you can do. So WPS got its hand slapped. And Trailblazers in Texas tried to do it too, and in Indiana, and a couple other places around, Virginia. So carriers have tried to roll this out, and every time Medicare said, no. This is a rule that makes sense. You can't tell doctors they can't do it. So the finishing statement is still an allowed process. Now, since you've got a template for it, I'm not going to go through this, but just here's some suggested ways that I think finishing statements don't make sense. Rest of system review is unremarkable. I don't know how many the rest is. You didn't tell me that you did a complete one. ROS not pertinent other than the HPI. Well, if it's not pertinent, I'm pretty sure you didn't ask about it. So that doesn't qualify. And so language that's suspicious, questionable, and then, better ways to say it over here. But you've got a box to work with your finishing statement, so I would go there. All right, family, medical, and social. I only need one statement from 2 of these 3 categories. In all other settings, and when we talk about observation care, but in all other settings, to get the highest level of care, you need a medical, a family, and a social. In emergency medicine, we only need 2 of those. So you're going to get the medical just, easy. So I need either a social and a family, a social or a family, one or the other of those. Not hard to document. Lives alone, lives with family, non-smoker, those are socials, no admitted drug use, socials. Easy to find, easy to get. But I need them to get a level 5. Okay, questions about the history?